CLABSI, a quality issue for nurse leaders. As healthcare providers, I'm sure we are all familiar with the term CLABSI. CLABSI stands for Central Line Associated Bloodstream Infection. CLABSIs are generally hospital-acquired or associated infections, commonly abbreviated as HAIs. Between 84,000 to over 200,000 of these infections occur yearly, and they are considered preventable infections. CLABSIs increase healthcare costs as well as mortality, and we will discuss these in more detail in the following slides. CLABSIs are most often caused by colonization on the skin, with different access sites harboring different levels of bacteria on the skin. The femoral and jugular sites were found to contain higher levels of bacteria than the chest or arms. Intraluminal as well as extraluminal areas of the catheter were found to be the main sources of bacteria introduction in central venous catheters. As the illustration shows, poor hand hygiene as well as medications that are infused through the catheter contribute to the increased risk of developing a central line associated bloodstream infection. What is the effects of a CLABSI on the patient as well as a healthcare system? The Agency for Healthcare Research and Quality stated that healthcare-acquired infections, including CLABSIs, affect 1 out of every 25 hospitalized patients, with CLABSIs having the highest mortality rates. Patients with CLABSIs are more than twice as likely to die than patients who do not have a CLABSI. CLABSIs increase the cost of the patient's inpatient stay upwards of $33,000 per patient. Now, this translates to about $21 billion annually in the United States alone. Because CLABSIs are healthcare-acquired infections, the Centers for Medicare and Medicaid, as well as many private payers, do not reimburse healthcare systems for the care required for CLABSIs. Because of this, the cost of treating the CLABSI is absorbed by the healthcare system. The Agency for Healthcare Research and Quality, AHRQ, has 5 recommendations to prevent CLABSIs, including proper hand hygiene, proper preparation of the skin with a 2% chlorhexidine solution prior to insertion, the avoidance of a femoral vein for central line site, full barrier precautions during central line insertion, and removing a central line once it no longer is necessary. Despite following these guidelines, a 36-bed oncology unit at a major medical center is still experiencing an increase in CLABSI rates. They employed 2 clinical nurse leaders who track the CLABSIs. They also have several policies in place to address central line dressing changes, continuous and intermittent IV tubing, and they also use central line insertion carts, bundles, and dressing change bundles. The 36-bed oncology unit also uses antimicrobial caps at the end of all lumens for central line lumens that are not currently being used. They also provide yearly education for staff, as well as use positive pressure caps on the end of all lumens. This diagram is a visual illustration of the steps that the 36-bed oncology unit uses to try to decrease the introduction of CLABSIs for its patient population. To help decrease the CLABSI rates, as nurse leaders, we must look towards the evidence-based recommendations. One evidence-based recommendation found in the literature was the use of a quality nurse. A quality nurse is a nurse who works Monday through Friday, 8-hour shifts, and the quality nurse has no other assigned patient care duties except for to help the unit decrease a quality issue. In particular, this case, the issue of CLABSIs. In the study, this quality nurse was trained by the medical director as well as the director of infection prevention, and this quality nurse attended daily rounds with the providers. All nurses on the pilot unit with the quality nurse received the same training as physicians on central line insertions. This empowered the nurse and allowed the nurse the knowledge to be at the bedside with the provider, and if there was a break in proper technique, it empowered the nurse to be able to speak up and say, no, we need to stop, this is not correct, I don't feel comfortable. The quality nurse was also there to observe central line dressing changes to make sure that they are done properly and in a uniform way. The quality nurse also performed daily assessments to determine central line necessity. The intervention of a quality nurse and the interventions by the quality nurse did make a significant difference in the CLABSI rates in the study. They decreased from 5 per 1,000 central line days down to just 1.5. This equated to 11.4 CLABSIs prevented in 1 year and over a $200,000 cost savings for the unit. When the quality nurse was removed from the unit, the results were not replicated. Another evidence-based recommendation found in the literature is the use of antimicrobial locking agents. One study that was found included a trial of 8 pediatric patients, all with implanted central venous catheters. All the patients had malignancies. Some were solid tumors, some were hematological malignancies, and half of these patients were receiving parenteral nutrition, which we know is another risk factor for developing a CLABSI. The agent used in this study, the antimicrobial agent used in this study, was an agent called Turolock. Now, we know that different agents work better for different organisms. Some may work better for gram-negative organisms. Some may work better for staph. Some may work better for fungal organisms. But this particular trial included the use of Turolock. And they found that this antimicrobial agent decreased the CLABSI rate from 15.2 per 1,000 central line days to 0 per 1,000 central line days. And this is the goal that we as healthcare leaders all want to achieve. A never event should be down to 0. A healthcare acquired infection, that should be our goal, to reach 0. And the use of antimicrobial agents in this particular study did reach that goal. The previous study we just discussed about antimicrobial locking of central lines was a study done on a small scale, only consisted of 8 patients, although it had great results. To add to the validity of that study, in Europe, the Renal Association, as well as the European Renal Best Practice, both recommended the combined use of heparin and taurolidine in locking hemodialysis lines. This practice was recommended as best practice by national organizations in Europe, and this should definitely have some validity in the United States as well as we move towards a goal of 0 CLABSIs. The role of the nurse leader in the implementation of an evidence-based initiative goes beyond the nursing process. Peter O'Grady and Malik discuss honoring excellence. What is excellence? Excellence is not perfection. We know in healthcare there is no such thing as perfection, although we aim for perfection. We know in healthcare that errors will occur. The key is to learn from those errors, to take those errors as learning experiences, to understand that errors support the evolution to best practice. Not every error needs to be a punitive error. We need to support staff during this time and allow them to be vulnerable, allow resiliency, and encourage creativity. To err is human, to forgive is divine. Proverbs 28:13 tells us, whoever conceals his transgressions will not prosper, but he who confesses and forsakes them will obtain mercy. as nurse leaders, we need to extend this grace to our employees as well as our coworkers. We need to encourage error reporting. We need to encourage learning from our mistakes. Romans 3:23 states, "For all have sinned and fallen short of the glory of God." Let our coworkers know that. Let our teammates know that we aren't perfect. We know they're not perfect, but we are in this together to provide the best health care that we can for our patients. Thank you for listening and observing this presentation.